I'm delighted to share with you some of the work that we've started to do with the newly formed Vital Research Network, which is being built up across Canada. And just want to acknowledge that I'm really having the privilege of sharing the work that's being led by many, many people, including on the slide my co-lead, Dr. Razak. But truly a collaborative effort of many folks across the country and even some on this call. So, um, we were pleasantly surprised to see just about 10 days ago, maybe just more than 10 days ago now, when Canada launched their new AI for All strategy, that healthcare was named as the first mission of Canada's AI strategy. And uh, that's a notable shift considering that about a year ago, healthcare, life sciences were probably not very much on the radar. And for a national AI strategy. And it's also notable that around the world, major AI companies have pivoted strongly toward healthcare. Pretty much every single AI company has developed a product line for healthcare, largely oriented around the United States. But this has become a phenomenon across the world. And it's perhaps also not surprising that uh, this is in the context of a growing and very serious public backlash or concern about artificial intelligence. So these are some statistics just about Canadians in a survey that KPMG did, in terms of Canadians' trust in AI. But we've seen globally, very low levels of trust in AI. And one reasonable framing around that is thus far, it's been very clear that AI has very real consequences in terms of energy consumption and maybe driving up local utility prices. There's climate impact, there's job disruptions, there's concerns about data privacy, there's concerns about youth and their use of social media and mental health. All of these are the very real and concerning potential harms of AI. And as yet, the true benefits of AI seem to be concentrated in the hands of a relatively small number of large companies, and not so widespread. And so perhaps it is not surprising then that a national AI strategy and also the whole industry of AI is looking to healthcare as a way to give people a good news story around AI and to sort of prove out a public benefit. And I think there's a couple of ways we can receive that as a healthcare and data community. So one is, it's certainly not an enviable position to be in to be like carrying water for all of AI, right? Like I don't think we want to be in the position of holding up the industry. At the same time, I- there seems to be an extraordinary opportunity to bring new data analytics and AI tools to address very real problems in our system. And two, um, there's clearly a moment of opportunity here where we can attract investment into healthcare that otherwise would not be, right? And so I think it's a big win for our sector that healthcare is named as a core part of this AI strategy and stands to receive additional investment to try to enhance our data infrastructure, try to enhance our capacities in the healthcare system. So it's kind of this ambivalence of, seizing the opportunity in front of us while also being, I think, very clear-eyed about the challenges that this broader sector faces. And then when we look in actually health-specific opinions of Canadians related to AI, this was a very recent survey. One is that lots of Canadians are using AI for medical advice. More than half of Canadians say that they've used a chatbot for medical advice. On the other hand, uh, most people also still say rather than getting an immediate diagnosis from AI, they'd wait 2 weeks to see their doctor. And this survey laid out actually three kind of broad themes of fears from Canadians about AI. So the first is privacy, real concerns about their data. The second is concern that for-profit companies will siphon resources from our public healthcare system in a way that doesn't benefit healthcare. And the third is that AI will become an intermediary that makes it harder for people to see their their care providers and damage those personal relationships. And so people really want to see these issues addressed in building a trustworthy AI system. I think the other thing we have to be very clear about is that this idea of some futuristic AI-enabled healthcare system feels pretty far away from the realities of healthcare on the ground in Canada today. I have the privilege of practicing general internal medicine, and like our day-to-day trials and tribulations largely orient around, you know, routine structures of care, how long our patients are waiting in the emergency department. I don't have a physiotherapist to help me, assess whether this patient will be able to go home today. And if our headlines in the newspaper are things like celebrating the fact that we're delivering eye masks and earplugs as a pilot project to help so that people can sleep in hallways, right? Connecting that to some futuristic vision of artificial intelligence feels feels like a big disconnect. And I think for those of us working in this space, we have to try to bridge that gap. So, you know, with my hat as a clinician and scientist, some of the areas to that, I would offer that we could actually act on to try to bring this idea of AI for all and harness this great energy around AI and actually make it useful in healthcare are one, build a connected data infrastructure that has to be closer to real time. It has to be more interoperable in terms of data structure and standards underneath it, so that all of these AI tools that are being developed can be developed and evaluated at scale, but also can be developed and evaluated locally before they're used and implemented. I think a second really important point is we have to meet our health systems where they are. We can't be delivering solutions that only work in some organizations that have advanced electronic medical records or advanced diagnostic imaging software suites. We have to think about solutions that will work across sectors. My sector is the hospital sector, which, already we're talking about the, most well-resourced sector in healthcare, but obviously we have to think even broader than that to ambulatory primary care, long-term care, etc., community care. Um, Third offering is that we should really focus our energy on solving real problems quickly and acknowledge that's going to be done imperfectly, and then try to pivot and iteratively improve from there. And I think we've seen that, for example, with the amazing work that HCR in Canada has done, which was, it took a lot to get this work up off the ground. The first projects are, not necessarily always pretty. That's certainly been the case for our work, but then you just improve and make the system better over time. And I think we need to be able to do that, and we need to be able to show wins that matter to Canadians early so that we can get momentum behind this. A fourth really important point is the need to rigorously evaluate, especially clinical AI solutions. I'll talk a little bit more about that. And then finally, of course, responsible governance around the data, around AI tools, etc. So broadly, these are, I think, areas where we need to focus. And so now pivoting to talk a little bit about what little piece of the pie, I have the pleasure of being a part of to try to move this forward, is the Vital platform. So Vital is a new multi-provincial platform that is working to connect near real time. So, what that means when we talk about it right now is daily updating hospital data across Canada. We've been grateful to receive funding from federal and provincial sources to really build this out. This will build as a very starting point in Ontario, Alberta, and Quebec. And I'll speak a little bit about the GEMINI platform that we've developed in Ontario. And I know I've had the chance to speak a little bit about it a previous session with HCR in Canada's community, so hopefully it won't be too repetitive. And then I'll really focus on some of the AI topics that we're talking about. And then what's been exciting and what Prime Minister Carney just announced is within that $210 million, an additional 100 million of that is to spread this across Canada. And so we have very little details about what that actually looks like. Honestly, it's at this point literally a newspaper headline, and there's not a lot of information behind that. But hopefully more forthcoming in the next couple of weeks. And what that we hope will mean is the ability to work with colleagues all across the country to build up this network. So core to our work has been building off of the rich and well shared administrative data, I will say well shared within provinces, and thanks to efforts of HTRN Canada and others, increasingly well shared across the country. But I know that that does still remain a challenge. But really, our contribution in this space is the clinical data from hospitals, the electronic medical records data. So looking at things like clinical notes, vital signs, transfusions, imaging, etc. All of that rich data that's part of the hospital digital record that historically has not been well shared. So today, Gemini works with about 45 hospitals across Ontario. They extract batches of that clinical data along with their administrative data. They share it with us at Unity Health Toronto. We de-identify, standardize, quality control the data, and then make it available. We make it available back to clinicians who receive individual practice feedback. We make it available to researchers all across the country. And, we've been grateful to see a lot of research projects as well as a lot of grants held largely outside of our institution, really helping us see this as a system resource, which has always been the aim. So I'll just talk about a couple of applications, and I know today's conversation was kind of oriented around AI. So um, uh, we started partnering with the Vector Institute, which is one of Canada's national AI institutes, um, about 2019 or so, 2018, 2019. Vector has all this amazing AI talent, but they were really struggling to access real world healthcare data. And so we worked with them to make the Gemini secure research environment where the data are held more usable for machine learning. So, get the right compute, software tools, etc., and make it a user-friendly machine learning environment. And thankfully, it's been quite successful. We now have about 40 health AI projects underway, and I'll just tell you about a couple of them. So one relates to sepsis. So sepsis is a massively burdensome problem of severe infections leading to disordered physiological responses. We know it affects about 100,000 Canadians, costs the system $2 billion annually. We also know that key to sepsis is early recognition and treatment. So it's been a focus of a lot of AI interventions that try to predict sepsis. The challenge is that sepsis um, interventions have not always moved the needle successfully. And importantly, there's a lot of bias latent in the sepsis algorithms because we know different groups receive very unequal care when it comes to sepsis. For example, people who are experiencing homelessness have much higher rates of sepsis and are treated much later. And if we train data on historical data sets, train algorithms on historical data sets, we'll propagate these biases. So we've been leading a CIHR funded study that works directly with people who are experiencing homelessness and collects additional data about housing, about people's sociodemographic situations, so that we can bake that into the AI algorithm development to try to address bias sort of upstream in the algorithm as well as downstream in the interventions. Um, a second project relates to this concept I talked about sort of meeting health systems where they are. So we know that diabetic foot complications are unfortunately very common. And we also know that limb amputations for people living with diabetes are devastating, but about 85% of them are preventable. We used data in Gemini to develop a predictor of patient risk for future limb complication, and then patients at high risk are streamed to proactive foot screening clinics. And this tool has been deployed and in use at one hospital, and we're looking to spread it now. The part about meeting the system where it is recognizing that automating this solution into a medical record is challenging, costly, and not feasible for many organizations. We created a simple calculator interface so that clinical teams can, within 30 seconds, generate a patient's risk. And so it's a immediately sort of spreadable, scalable solution. And I think it's important for us to think about AI tools in that fashion. The third project I'll talk about is in a little bit more depth is our aim to prevent delirium project. So delirium affects about 20 to 30% of hospitalized adults it can be profoundly distressing when a patient in hospital becomes disoriented, not only for the patient and their family members, but also for the healthcare providers looking after them. It's one of the leading causes of workplace injuries when people become disoriented and they aggressively lash out, not for any fault of their own. And so, with all of those burdens, it's associated with worse healthcare outcomes and much greater cost in the system. Roughly 500,000 Canadians experience delirium every year. That's roughly $10 billion of cost to the system. What's amazing about delirium is about 40% of cases are preventable, and they're preventable by a bundle of interventions, which sound like just generally simple and straightforward care, like being cognitively stimulated, helping people move, sleeping well, seeing and hearing, staying hydrated, eating well. One of the problems is hospitals seem to be purposefully designed to do the opposite of every one of these things. It's hard to sleep, you don't get good food, you're often tethered to your bed, and it's hard to get up and move. All of these things. And it's very resource intensive, especially nursing intensive, to try to deliver this bundle of interventions. And so this bundle is not delivered well. So our idea was that we could perhaps risk stratify patients for delirium prevention interventions. And so we created a prediction tool using GEMINI data that generates a delirium risk score. One of the challenges with research with clinical data sets, large scale clinical data sets, is they don't capture delirium very well. So routine data, whether it's admin data or uh, clinical documentation data, captures only 25% of delirium cases. And so what we did was we were fortunate to receive some CIHR and NSERC funding. We used it to create a linked data set where we did this chart review method, which is very reliable, but takes 30 minutes per patient record, to generate a large data set of about 10,000 patients across 7 hospitals where we have very accurate delirium diagnoses. And then we use that to train our model. We created a model that can predict delirium risk. And coming back to the idea of making these tools usable, the initial model we started with had roughly 450 inputs, things like age, diagnoses, lab tests, vital signs, all of these different things. And when we did the first model had a roughly 80% accuracy at predicting delirium in hospital. What we found was we could dramatically simplify the model. I think our final model now actually has 10 inputs without trading off too much accuracy. So it's about 70% accurate. And what that means is it's dramatically easier to use. So a model with 450 inputs would be very hard to deploy at scale, but a model with 10 inputs, much easier to deploy using a simple calculator or to engineer into a medical record system. And so that's what we've done, and we've then defined this delirium set of delirium prevention interventions. I think one of the other things we've learned with AI is you can predict anything. What's more challenging in healthcare is to find prediction targets where we already have evidence-based interventions that can improve outcomes and that can actually meaningfully change something if we had a prediction. And so, fortunately, with Delirium, we have that bundle, and so we worked with our local teams to adapt this bundle and make it implementable for a subset of patients. So we are trying to implement this full bundle, but only for 25% or fewer patients on a hospital unit, as opposed to trying to do it for everyone. And the hope is that that risk stratification will allow us to really focus on the patients who need this the most and properly deliver delirium prevention interventions for them. And so we're now rolling this out in a hospital level cluster randomized control trial that will include 15,000 patients across 13 hospitals. To our knowledge, it's Canada's largest clinical trial of an AI solution, funded by our provincial government, and we're really excited to have been working with a very large team to bring this forward. I'll just make one last comment about delirium that hits me in quite a profound way. This was data from GEMINI that a research group looked at. They compared patients with an English language preference and a non-English language preference and what happens to them when they develop delirium. Patients who have a non-English language preference are 2.5 times more likely to end up physically restrained. That means literally tied to the bed when they have delirium, or to receive a chemical restraint, an antipsychotic sedating medication, than people who speak English. And from a clinical perspective, while deeply saddening and concerning, is also understandable because if you can't speak to someone to de-escalate them when they are disoriented, it worsens their disorientation. And you can be misinterpreting their reactions as threatening. You can, there's a lot of reasons why this is a believable thing, but it just speaks to the profound equity implications of being able to do this work well. And if we are able to, generate models that help us reduce delirium in an unbiased way, we could potentially be mitigating a lot of really serious harm and disproportionate harm. It could be an example where AI not only is sort of not becoming more biased, but it is actively mitigating bias in our healthcare system. Okay, I'll just give two other brief examples of ways that Gemini data have been used. So in order to ensure that hospitals are interested in sharing data, we have to be able to provide direct value back. The research projects I told you about, the delirium one, the diabetes one, sepsis, they all have very long windows, right? Like it takes years to develop these tools to get solutions back out. For hospitals, especially non-academic hospitals, the idea that they would go to the effort of extracting data and sharing it with a network isn't so compelling if the only value add is a research value add. And so the core reason most of our hospitals have participated until now is because we deliver back quality reports. And look, there are millions of dashboards in healthcare that are delivered all the time. Um, I think what's been successful about this, so what we do is we deliver individual physician practice feedback as well as hospital level benchmarking reports. But the piece that I think is more successful about this than a general just dashboard people can use is that our provincial health agency, Ontario Health, convenes a community of practice, which involves frontline clinical leaders, it involves hospital administrators and executives, and they come together monthly or quarterly, depending on the year. They look at the data, they talk to each other, they learn from each other. There's a sort of facilitated knowledge exchange. So it's kind of a learning collaborative. And also out of that learning collaborative comes sort of network-wide campaigns. So it's really that dynamic process of getting engagement around the data that also being informed by the data. So the combination of those two things that has been successful, and we were able to show um, a pretty important safe efficiency gains. So in the first 18 months of the hospital benchmarking program, we saw about a 50,000 day reduction in patient bed days in hospital, which on the one hand is important, avoiding costs in the healthcare system, and on the other hand, as a clinician, the thing that makes me the most heartened by this is in our lowest performing. I say that in a way that I don't mean to be pejorative, but the hospitals that had the longest lengths of stay at the baseline, they were able to improve their hospital lengths of stay so that patients were staying in hospital 1 day shorter. That's 1 day less spent in a cold emergency department with people suffering. So, been grateful to see that impact. Um, Building this infrastructure also creates capacity for system resilience and response to emergencies. So we were able to produce some of Canada's first data around the pandemic. We were also able recently to produce a list of priority medications for hospital care when supply chains were threatened by American tariffs, because hospital medication prescribing is a major black box at a system level. Most of that happens through bulk purchasing, and so we don't have a good sense of how medications are being prescribed and used. And so, the opportunity for us now at scale to harness EMR data to do that, where insurance claims data were not reliable in the hospital setting, or didn't give us information in the hospital setting. That's a new capacity, and we're excited about that capacity. So the challenges with Gemini historically have been that it's only one province. A big challenge is that the data are not real time. We receive data with a 12-month lag from most sites, 3-month lags from some sites. Um, Historically, Gemini does not have indigenous governed data sets as part of it. So that has been a big gap. And then private sector partnership was not permitted. So all of these data are collected under research agreements with hospitals. And in order to gain everyone's trust, 10 years ago when we started this project, we just took any industry sponsorship off the table. So when we look internationally, we of course see large investments in clinical data that are, in order for us to stay competitive, in order for us to do research at the leading edge, and also to get improvements in healthcare in Canada, we need to be able to do better. And so Fahad and I wrote about this in the Globe, and what we said was that if we can address these issues, we can actually be the best data set in the world. I don't need to convince this group about the value of data. I'll just say, the fact that we're a diverse, high-income population, and importantly, we have the scientific community that knows how to use the data is really important. And so we were very grateful, having made that case, that federal and provincial governments have come together to support us to build this. And so what is this going to look like? I'll speak a little bit about it in this slide and the next slide. Um, so the funding that we've received is to really build out this infrastructure layer. So the first is automated data pipelines to extract data from hospitals where that's needed, some provinces that's needed, and or to plug into existing infrastructure where that's not needed. I think I saw Jeff and maybe some others on the line from Alberta, where they're fortunate to have a single Epic implementation for the province. So we're building data pipelines that are a little different there, but that's the first step. Get the data into a usable environment. The second step is to be able to link actual images to clinical data that will unlock a wide variety of research applications. So the first, some of this capacity already exists. So our first three provinces are Ontario, Alberta, and Quebec. Alberta has quite a mature infrastructure, particularly around cardiac imaging, based out of the University of Calgary around this. Quebec has some pockets, especially at the institutional level, that is doing this linkage really well. Ontario has a single consolidated imaging repository called OCINet, and OCINet holds roughly 200 million medical images that have really not been used well for research because the organization doesn't have capacity to make it available for research. And so some of this funding will go towards making those data usable for research. A third component is to build out the secure computing environments in each province. So critical to this work is we have to respect provincial authority over health data. And so the architecture builds a single secure environment in each province that can then be connected using federated analytics, very analogous to the approach that HCR in Canada is taking, where we are focusing some of our funding and efforts is to advance those computing capacities, because in a federated environment, you still need the compute where the data lives. So if you're trying to do some machine learning intensive project, you need the GPUs in each province to do the federated learning. A fourth component is to advance linked Indigenous data under Indigenous-led and governed research collaboratives and initiatives. Our first project in Ontario is under the leadership of Dr. Janet Smiley, as well as partnerships with the Indigenous Primary Healthcare Council and Seventh Generation Midwives Toronto. And the idea is to link data from Indigenous primary healthcare organizations with hospital data to create a usable data set, not only with reliable Indigenous identifiers, but also that has the ability to deliver back to Indigenous healthcare organizations notifications when Indigenous patients come to hospital, so that those organizations can assist with care navigation. And we're just working through, a lot of the really important details around that and around the governance of that. A fifth core capability of the platform is to create a user portal. The idea is for there to be a one-stop shop in order to explore the data that is available, as well as analyze the data, and then within that platform to host software for clinical trials, software for machine learning, artificial intelligence, etc. And then finally, this all needs to be wrapped in governance, privacy, and security layers. Today in Ontario, GEMINI has a REB governed data access process that we've been able to get quite streamlined. So the 90th percentile turnaround time from project proposal to first project approval is 12 days. And recognizing that harmonizing this across many provinces is going to be a much more challenging task, but we think it's really important for us to try to hold ourselves to some similar types of benchmarks for data access. And we have the benefit in some ways of um, starting a little bit from scratch in the hospital sector, working only in one sector of data as a starting point. And so that's what we're aspiring to. We're also building out the governance for industry-sponsored studies, and have been really grateful to HCRN for some of the leadership that they've done in that work. One thing I'll just say, not on the slide before, is we are actively thinking about what linkages to administrative data in each province look like. I would say that that's a very still early days in our thinking. I think we're consumed enough with the idea of trying to get real-time EMR data out and make that functional. But we certainly see that as being a critical component for, assessing long-term outcomes, pre-hospital care, all of those things that are really important. So that's work in progress. I think I've spoken about this, the idea that data remain within each province. We're harmonizing in order to enable the federated model, you need to harmonize data standards, which is some combination of OMOP, high standards, et cetera. And we'll be very aligned with what is happening through the HDR Alliance and all different kinds of data partners is where I think we're all broadly rowing in the same direction. Um, and just say that we've been very grateful to have a strategic advisory committee that has a very national scope. So really grateful to David Naylor for chairing, and then to have the former Minister of Health for Canada, Ron Ambrose, and then deputies, privacy commissioner, CEOs, hospital CEOs, people from industry, really from many provinces across the country. And I think the reason for sharing that is to say this really has to be an infrastructure that works broadly across the country, and that requires a lot of, I think, careful discussion, compromise in some cases, and we're really grateful to have a group of people advising us and trying to help move that ahead. We're very mindful, like my talk today, I will say I'm already has been very anchored in our experience in Ontario. And that doesn't reflect nearly a sliver of the experiences across the network and the capabilities, which are so impressive in different provinces. And so, part of this is also starting to try to work at a much more national scale. I'll just close with some example use cases that we're bringing forward through Vital. So the first was a project that we've completed with Jeff and his team in Alberta. This was a study commissioned by Canada's Drug Agency. They specifically asked us to look at hospital medication prescribing and variations in the prescribing of different drugs. We looked at opioids, sedative hypnotics, antipsychotics, and antibiotics. And what we found was really large variations in the way different medications are prescribed across our different hospitals. And as I mentioned before, it speaks to really, I think, the exciting opportunities of harnessing EMR data to help standardize care. Where we're moving now with the exciting research studies, there's a project looking at predicting cardiovascular events using routine cardiac testing. There's, I think, a really big application for this work around automated patient matching into clinical trials. And then we're looking at public health surveillance types of applications, looking at automated detection of respiratory illnesses, for example. So obviously a large suite of use cases, potential use cases. In the interest of leaving time for discussion, I think what I'll do is skip over what this next section is literally just saying what we hope this infrastructure will do is improve Canadians' access to medical innovations by bringing more clinical trials to Canada, improving the equity of participation in clinical trials by having more hospitals be part of a network where more patients can be given the opportunity to participate in clinical trials. Attracting investments, whether it's in clinical trials, AI, other kinds of research to advance Canada's economy and prosperity. And then really building a Canadian solution, right? I think there's a whole discussion around data sovereignty, data residency, and governing data within Canada. That's important. But there's also this important component of having an innovation capacity within Canada so that our scientists are not turning to American technologies or data sets to do their studies, because we know that tools developed internationally, especially in American settings where, not all patients are included, not as diverse population. it won't necessarily translate well. And healthcare is very different there, obviously. So I think for all sorts of reasons, there's really important sovereignty imperatives, and we hope to advance that with our work. Final thought is we're really grateful that our government are seeing this health data as a critical national infrastructure and seeing the implications of it widely for improving healthcare, but also improving the economy, security, and sovereignty. And I think my closing thought will be just that we are at this interesting moment in AI. I think analogous in some ways to the advent of new technologies that have happened many times. A simple example is the MRI scanner. When the MRI scanner came in, uh, it was this new, really amazing technology, but we didn't really know how to use it. And it took decades to figure out that the MRI is really good at neurological lesions. So when someone comes to the hospital with a spinal cord compression, I know they need an MRI, but is terrible for pneumonia. And that clarity of where we are going to be able to use medical AI is yet to be determined. And I think that's where the opportunity for a research and innovation infrastructure like Vital is particularly important and relevant, where we need to help our healthcare system not only develop and evaluate new solutions, but really importantly, to decide which solutions are going to work well locally for our populations, evaluate that from a health technology assessment perspective, help the system make good investments. And I think having that capability will be really important for protecting our healthcare system as we go through this, exciting but disruptive transition that's happening around AI.